At the moment, we have access to enzalutamide for patients with metastatic and castrate-resistant disease, and along with abiraterone, that's been a standard treatment for a few years. What we've seen earlier on this year is data presented for patients with castrate-resistant disease, but without evidence of demonstrable metastases. And two studies, one testing enzalutamide, the other apalutamide, both of which were large, well-conducted phase 3 placebo-controlled studies, have shown an improvement in metastasis-free survival. I have to say, I think the results are strikingly similar between the studies, and in terms of the efficacy endpoints, I don't think there's an awful lot to choose between them. We've yet to see an overall survival result in either study, and I think that's going to be important in terms of whether or not this is a treatment that these patients should be exposed to, because actually these people are generally asymptomatic, and there is a question still, I think, about whether one should launch into treatment. An overall survival advantage, I think, would probably tip many clinicians over into feeling it was the right thing to do. We haven't got head-to-head data. We don't have a comparative study to tell us about relative toxicity from treatments or indeed efficacy. I think that's probably unlikely to happen, and to a degree I think clinicians will probably need to base their treatment decision on their experience of using these drugs, and probably as they get used to treating people in this setting, assuming that's what they choose to do, whether or not they do come to feel that there is a difference in toxicity, but at the moment there is really no evidence to suggest that that exists.